Hello and welcome everybody to this webinar. This webinar title is Sustaining Containment of COVID-19. And I am your host, Dr. Randy Katz. I'm a graduate of Nova Southeastern College of Osteopathic Medicine here in Fort Lauderdale. I am the medical director and the chairman of emergency medicine at Memorial Healthcare System. And I also serve as the medical director for the City of Hollywood Fire Rescue and the associate medical director for the City of Pembroke Pines. So I've been very involved in the COVID-19 crisis and have both planned at the hospital level and the community level. And now we are planning the second phase of this pandemic, and that is the reopening and how do we get back to normalcy and how do we recover from this pandemic. This is the sixth webinar offered by Nova Southeastern Division of Advancement and Community Relations. It's being streamed on Facebook Live and will be available as a resource online. So I'm going to start the quick presentation. It's going to be about 20 minutes and there'll be some time for Q&A afterwards. You can send in questions and we'll answer a few of those. So with that, we're going to go ahead and get started. My first slide here is really kind of says it all, sort of demonstrates the dilemma that we're in right now. On the left side, we have the pandemic and the impact it's had on our society and the healthcare systems. As you know, New York City and some other cities were hit very hard by this crisis. Early on, a lot of those graphs and exponential curves that we were watching seemed like they were never going to end. And we know that we've had many people in our country die from this disease, and many people have been impacted on the healthcare side. On the right side, on the other side, is really the other collateral damage items that this whole pandemic has caused. You know, the stock market has depleted people's 401ks. There's somewhat of a mental health crisis, I can tell you, here at the hospital level in the emergency department. Definitely increased number of mental health visits. People that are out of work. It's very complicated and difficult, obviously, for those people to feed their families and pay their rent. Increase in drug and alcohol abuse for sure. And we've actually seen an increase in suicides, both on the hospital side and the healthcare systems, particularly in New York, as you've seen in the news recently, but also in the general population. The next slide is really a depiction of the numbers from some of those things that we just talked about. And these slides were produced a couple of days ago, but at the time, there were a little over 1 million confirmed cases of COVID-19 in the United States and over 58,000 deaths in the United States. And actually a couple of days ago, that death toll surpassed the total number of US soldiers that died in the Vietnam War, which is not something that we should be proud of as a country. It's clearly impacted us tremendously here in the United States. And I thought this next set of statistics really said a lot to me. You know, the United States makes up 4.3% of the world population, yet with COVID-19, we make up 32% of the cases in the world. We know that there's probably some countries and, probably third world countries that underreport deaths. There's been some news about China underreporting, but either way, clearly there's a huge gap in the number of people we make up in the world and the number of infections we've had in our country. So this country has been hit particularly harder than most other countries, which has been very painful for the citizens of the United States. Because in the news, we see a lot of numbers and statistics being thrown at us, it's really important to understand statistics on the level of a statistician, so to speak. So I'm not going to go into an hour dissertation on statistics, but I wanted to break down the numbers a little bit so people better understand what these numbers mean. If you look at the number of people that have tested positive in this country, overall, early on, we were only testing, remember, people that had travel history for a long time, for the first few weeks. Then that testing indication expanded to people over 65, people that had comorbidities like diabetes or COPD, which is a lung disease, and eventually expanded to all people with symptoms. So when we look at how many positive cases we have to keep into consideration that we were not testing everybody early on. But if you look at all of the tests we've done as a country, we've tested 5.7 million people. And out of those people, a little over 1 million of those people tested positive, which is about 17%. Here in the state of Florida, it's very interesting in that the epidemic has really been confined to South Florida, so to speak, where 60% of the cases in the state of Florida involve Dade, Broward, and Palm Beach County. And there's counties in the state of Florida that have not had one case of COVID-19, which is very unique. I think every state has an epicenter that has cases, and Florida, South Florida is clearly the epicenter of this epidemic in the state of Florida. But we have to understand that when we talk about 17%, we're not including people that may have had the infection that didn't seek medical attention. We're not talking about people that had minor symptoms and didn't realize that they had the infection. And I know that a lot of people have come to me and asked me, or have told me that they're pretty sure that they've had the infection because they were sick back in January or February, and they know that they had the infection. And we know the infection has been here for quite a while, much longer than we think, probably early January in the United States. I used an example here, and if we look at antibody testing, which is one form of testing, which we'll talk about in a little bit, New York, because they were so hard hit, they wanted to know how many people were actually infected in their state. And they did an interesting study. What they did was they put representatives outside of grocery stores and randomly selected people coming out and did antibody testing on these people. And they put testing stations in New York City, the center of the epidemic, Long Island, which is, not far from New York City, Westchester, which is a little further north, and then upstate New York, which involves a lot of rural areas and areas that are not so close to New York City. And what they found was that 21% of the people they tested, and remember, these are people that have zero symptoms, people that have never had COVID-19, they're in this grocery store shopping. 21% of those people had antibodies, which means that the infection rate is much higher than 17%, or I should say much lower percentage, but a much larger group of people. And that gives you a little insight into what goes on into some of these cities. I could share some numbers with you in Florida as far as infection rates, but we have not done widespread antibody testing. So we really don't know how many people here in South Florida have been infected or have had the infection and have antibodies. So this is an interesting graph, and a lot of people want to know, have we reached the peak? Where was the peak of the infection? And I think this graph kind of says a lot. What it shows is the number of tests that we've conducted in the state of Florida as a whole. And as you can see, we started testing people in mid-March. And this is a little bit outdated, this graph, but it does show you that we ramped up testing pretty quickly, and then it sort of plateaued. We ran out of capacity, essentially. We didn't have enough testing kits. We didn't have enough labs, and we were only able to test a certain number of people. And when we look at the peak, which was right around April 5th, between April 5th and April 12th, at that point, you essentially showed about a 10% infection rate, meaning in the state of Florida, about 10% of the people we tested were positive right around that time. And what's encouraging is that number, if you look at the graph to the right, has come down to about 7%, meaning there's less and less people with the infection that we test over the past few weeks, which means to me the peak of this virus, the apex was somewhere between April 5th and April 12th. And a lot of the initial graphs and prediction models predicted the first week of May, and then they went back to the last week in April. But this graph clearly shows you that the peak of this virus in the state of Florida, and probably South Florida, was a couple weeks ago. The next slide looks at fatalities and asks the question of how deadly is this virus? And a lot of questions have been asked about influenza, and isn't the flu just as deadly? What's the difference between this and influenza? And the two terms I think you really need to understand are case fatality rate and infection fatality rate, meaning for case fatality rate, it means how many people that acquire the infection die. Infection fatality rate means how many people in your community are going to die when you have this infection. And when you look at the case fatality rate in New York City, it was about 7.5%, meaning of all the people infected, about 7.5% of those people will die, which is a pretty high case fatality rate. But case fatality depends on a lot of things, which we'll talk about in a minute. When you look at infection fatality rate and you take the total population that's in that city or that area, and you basically use that as your denominator, and you look at the number of infections you've had in your community, it's a little less than 1%. So about 0.75% of the people in New York City have been infected or actually have died from an infection with COVID-19. If you compare that to influenza, influenza is 0.1%. So every year when we have an influenza epidemic in this country, about 0.1% of the people die from this infection, which is a very low percent, but when you're talking about 300 million people, it's a fairly large number of people. When you talk about 0.75%, and let's just say we round that to 1% in the United States, 1% is about 3 million people. And we know we have not had 3 million fatalities in this country. So it gives you an idea of how deadly this virus can be, even at a very small percent, but the percents are a lot lower than the initial percentages we were seeing from Italy and Spain and some of those other countries. And the reason is that fatality and mortality really depend on not only the virus itself, but hospital capacity. We know that Italy and Spain, from some of the videos and pictures we've seen and some people I've spoken to that work in hospitals in that country, the healthcare system was absolutely overwhelmed. And when you don't have enough ventilators and enough providers and enough beds to put people in, eventually people are going to die from that. It also depends on comorbidities, meaning who has diabetes and hypertension in your community and what is the incidence of those comorbidities. And we know places like New Orleans had very high mortality rates because we know that diabetes and hypertension is very prevalent in those cities. New York also has a fairly high rate of diabetes and hypertension, whereas some states like Colorado have very low rates. So it depends on many things. And when we look at case fatality, it's not just the virus itself. This graph, I think, really said a lot to me about this particular virus. And when we look at coronavirus, we want to know, how does it compare to all these other viruses? And this really shows you two things. If you look at the y-axis and the x-axis, right? Going to the right, it means a virus spreads faster. So if you look at measles and chickenpox and basically the common cold, these are things that spread very, very easily. But they're not so deadly, meaning that on the x-axis, they, going up, they don't kill a lot of people. And for a virus that's very deadly, meaning something like Ebola, which you see here at the top, Ebola is a very deadly virus. But as you can see, when it infects somebody, it kills them pretty quickly. And the good news with Ebola is that when people get infected, they don't spread it very quickly, which is why most of these Ebola infections and SARS infections have been containable. And we've avoided the situation we're in now. Because when you get infected, you get sick very quickly. You don't walk around spreading infection. You pretty much die in a very, very short period of time. And the problem with coronavirus is we sit somewhere in this central area right around Spanish flu, which essentially means that the virus is fairly deadly and it spreads fairly quickly compared to, let's say, the common cold. And that combination of deadliness and quick spread really has been the reason why this virus has created so many issues. So to the question that we're trying to answer right now, and the reason for this lecture, now that we understand a little bit about the virus and the impact it's had, is really looking at how do we reopen society? How do we move forward and get past this first phase that we've moved through, which has been horrendous? And the federal government, as well as our state government, have really put together some guidelines. And these are the guidelines. We first need to see a downward trend in influenza-like illness presenting to hospitals for a 14-day trend. We're about there. We've seen that. We know that from that graph I showed you earlier. We've seen less and less patients test positive, which is the second trend we need to see. And the third trend is number of hospitalizations. I could tell you here in Broward County, the number of hospitalizations in our healthcare system has definitely gone down for at least 7 days now. We're close to 14 days in a week. And then the other question is whether hospitals can treat all patients without crisis care, meaning do they have enough ventilators? Do they have enough beds? What's the capacity of the healthcare systems? And I think as healthcare systems in South Florida, we're in a pretty good place for the most part. The last data point, and the reason I highlighted it, is that is the one thing that is really missing in our community, and that's robust testing programs in place. And that's something that the federal government and the state government has really mandated. And that's something that, unfortunately, we're not there yet. And without that one piece, we do run the risk of another second wave of this pandemic. And it's something that we really need to focus on, which I think the federal and state government has been very focused on, as most of you know in the news. If we look at just where do we stand with testing, as you can see, the state of Florida, ramped up testing. We started testing people. And as you can see over time, the testing sort of plateaued. And the reason is that we ran out of swabs. We ran out of reagents, the liquid we put in the machines to run these machines. And we only had so many machines available to perform these tests. So the federal and state government have been very focused on increasing capacity, which they've done. And at the same time, we've seen the number of new cases go down. So the testing will become extremely important when we move forward into this next phase, because as we see less and less cases, when we do see, let's say, an epicenter somewhere that's erupting, testing will be the only way we can quickly identify and trace people and contain the virus. So when we look at reopening, and the state of Florida, as I mentioned, is very unique in that, there are a number of areas, and if you look at these areas in the north here, and I'll highlight them, these areas up here in pink, these are counties that have had 0 COVID-19 infections. So there are other places down here in South Florida that are actually red, which are hard to see on this graph, but these are places that have very high concentrations, places like Hollywood, Florida, and Miami, and places in Dade and Broward County and Palm Beach. And the government has decided, both the federal and state government, and the federal government did decide to allow states to reopen and progress on their own timelines, because all states were on different timelines, which I think was a very thoughtful approach to reopening. And the state is doing the same thing, as you can see from the governor's executive order yesterday, which I think is very well thought out. There's no reason why we should delay reopening in North Florida when they haven't had any cases of COVID-19, but yet South Florida was left out of the executive order, and we were asked to continue quarantining and staying at home and doing the things that we're supposed to do through this crisis. And we're delayed a couple weeks now, or maybe a week or 2 weeks. It's unclear. It really depends on the numbers of people coming to the hospital and the number of positive infections we have. So the question has been answered as of yesterday, and I created this graph on Monday, or this slide. So do you open all at once, or do you do it in areas that have low incidence first and then high incidence later? And that's what we've decided to do, which I happen to think is the right approach. And the next slide is really important, because this, to me, really answers or begs a lot of the questions that we have. Let me just delete that, sorry. So this is a depiction of the evolution of the Spanish flu in 1918, which is really the only historical comparison we have to this virus, a virus that spreads very quickly, that's fairly deadly, very similar type of spread with this virus and mortality rate. And unfortunately, the 1918 Spanish flu killed 17 million people, and about a little over 500,000 people in the United States. So this was an extremely deadly virus. And as you can see, if I highlight this first area here, which is this hump, that's where we're at now. And if this were the Spanish flu, this is where we could be. And you could see that on the second phase of this virus, the second peak, it was 5 times as deadly as the first peak. And that's what scientists and epidemiologists and governments fear, is that if we get complacent and we let this virus progress and see numbers coming lower and let our guard down, we could wind up with this scenario, which is a real possibility, but there are a lot of unanswered questions and things we don't know. The one thing that people don't realize, and one of the pieces of information that's been left out from the 1918 Spanish flu epidemic or pandemic, is that the virus did mutate, meaning the virus during the first peak looked one way from a molecular level. The DNA itself changed and mutated between the first peak and the second peak. And that virus became much more deadly during the second peak, not only because of the way it spread, but because the virus itself changed the way it infected people. And that's something that very well could happen with this virus. May not happen. We don't know. And that's the problem, is there are a lot of unanswered questions and things we still don't understand about this virus, which is why we need to be very careful. And as a society, we need to be very cautious with how we move forward after this quarantine is lifted. And this is a really interesting slide, because it does show the differences between cities during the Spanish flu, and how social distancing is extremely effective, and how it can impact the number of people that die. And we know that in this country, the initial estimates were much higher. The death tolls and the estimates of the number of people that would die from this virus, the COVID-19 virus, were much higher than where we're at now. And that is really directly related to social distancing. So if you look at these two cities during the 1918 Spanish flu pandemic, Philadelphia, as most of you have probably seen in the news, had a parade, and the parade was allowed to go forward, and they did not enact social distancing very quickly. You know, they waited a fair amount of time, a couple of weeks before they did anything. And if you look at the death toll in Philadelphia, it was extremely high. If you look at a place like St. Louis in comparison, the death toll was much lower, but spread out over time. And that was because social distancing was enacted very early. And I think the social distancing that we did in this country was done fairly early, I think particularly here in South Florida, which has really spared a lot of lives and really helped us avoid overwhelming our healthcare systems as they did in some other countries and New York City. And my guess is that the virus was probably in New York City for months before it was detected, which was why the peak was so high and social distancing was enacted very late in New York City. Not intentionally, but because they didn't realize the virus was living in their backyard for so long. So here's a statement from the National Governors Association, and it says, opening prematurely or opening without the tools in place to rapidly identify and stop the spread of virus could send states back into crisis mode, push healthcare systems past capacity, and force states back into strict social distancing measures. What this means to me is that all of those measures, those criteria that I mentioned before, like, you know, hospital capacity, lowering, seeing the number of infections coming down, and testing. And the one thing I had mentioned before that we don't really have enough of is testing. And if you look at testing, it's very complicated. A lot of people don't quite understand it. So I wanted to talk a little bit about testing so the general public understands a little more about testing, because this is going to be the key to containing this virus and avoiding another peak in this pandemic. In healthcare systems, and I can tell you in the healthcare system that I work in, we're really looking at COVID-19 testing as the fifth vital sign. So when you come in and you get admitted to the hospital, you have surgery, you'll have your blood pressure, your temperature, your heart rate, your respiratory rate, and your COVID-19 test done. And that will help us decide how to manage somebody, you know, as far as where to keep them in the hospital if they should come to the hospital and they have COVID-19, and really avoid infecting our staff and other patients in the hospital. So testing is really important, and it will become commonplace in all hospital admissions, all elective surgeries. Everybody will be tested when they come into the hospital. It really is the only way as well that we can assess the impact of the changes we make. If we lift all of the barriers we have in front of us now and we allow businesses to open, the only way we know what is happening is through testing. And without widespread testing available, where the general public, if they get sick, can go and get a rapid test and get a result fairly quickly, without that ability to do that, we really don't know what's going to happen in our society quickly. And we can be 2 or 3 weeks behind a curve that's too late to turn back. So testing is really important to assess the impact that our changes are going to have on society. And it's important, and I know a lot of you have been asking me about this antibody testing and molecular testing, the nasal swab. So just to kind of explain that a little bit, antibodies are basically your body's immune response to an infection. And one way to look at somebody's body's response is to measure their antibody levels in their bodies, or the presence or absence of antibodies. And if you have antibodies, it means you've been exposed to the virus. It doesn't necessarily mean you're immune at this point. We don't know the answer to that. But it does tell you a little bit from a historical standpoint on whether you've had the virus or whether you actually have it at the present time. And there are false positives and false negatives, which I'm not going to go into, but antibody testing measures antibodies, and that's done through blood. Molecular testing is these nasal swabs or oral swabs or saliva tests. And these are basically tests that involve taking a sample of tissue basically and looking under a certain type of machine, whether or not there's viral particles there. So it only detects active virus, people that are actively infected, but it does not tell you anything from the past, whether you've had an infection, whether your immune system has responded to it. It really only tells you whether there's virus present in your body, which is extremely important, but nevertheless a different bit of information than antibody testing. So when we talk about diagnosis and we want to know whether we have the virus, that's molecular testing. That's what we do, is we swab the nose or take a saliva sample, and we're trying to make a diagnosis. That's the most accurate way to make a diagnosis. Some places are pushing antibody testing for diagnosis, and I'd be very, very careful about doing that. It's unreliable. It's an unreliable way to diagnose COVID-19, active COVID-19 infection. I would highly encourage people to avoid antibody testing if that's what they're trying to do. Antibodies do tell you your immune status. So, if you've had the infection and you have antibodies, and I'm not going to go into the types of antibodies because there are different types, but certain types of antibodies present may mean that you're immune to the virus and may not get infected again with it. But we don't know the answer, but it does help let us know whether you've had antibodies or not, which, doing a lot of random testing and surveillance in communities, looking at people's antibodies, which we'll be doing here in the community that I live in through some of our cities, of working on a protocol for City of Hollywood and Coral Springs and Davie. But we will start looking at antibody testing with some of our first responders and seeing who's had it and who has antibodies and that type of thing. With viruses, there are vaccines, and I'll talk a little bit about vaccines in a minute, but antibodies that are produced from a vaccine can be measured, and that's the way we tell whether a body's response to the vaccine was effective. So whenever we have a vaccine, the antibody testing will become really important to tell you whether or not you're actually immune or have developed an adequate antibody response. And then surveillance can involve both. If we're looking at a community and want to know what's going on really quickly, we can measure antibodies and molecular testing and combine the two, and we get a lot of information from both of those. Here's just some pictures so you understand. The antibody testing can be done in a lab. It can also be done with sort of a pregnancy test approach. We call that point of care. And that little test kit that you see, it says COVID-19 Biomedomics, is just one brand. There have been a lot of issues, as you guys are probably aware of in the news. China produces most of these test kits. Some of them have been pushed through customs and are invalid or have a lot of false positives. So be very careful. These need to be validated before they're used. And don't let anybody just do an antibody test kit. Make sure you're going to a reputable source to do that. The molecular tests are these nasal swabs and saliva containers, and they go into a machine, and the machine basically detects the presence or absence of the virus. Unfortunately, the United States is somewhat behind other countries when it comes to testing. If you look at the number of tests we've done based on our population per 1,000 people, we're actually somewhere in the middle. We've probably gone up a little bit from there, but there are countries like Israel and Italy and Lithuania who have tested a lot more people in their country. And when you look at state by state, Florida is not doing so well when we look at capacity per 1,000 people. Florida needs more testing, and because South Florida is an epicenter, testing is extremely as important, as I mentioned. So the question is, what will things look like? And I'll go through these line by line real quick, and then we'll wrap things up in a few minutes. But again, widespread testing with antibody and molecular testing will absolutely be everywhere. You're going to see more and more of it. There'll be more testing stations. More doctors' offices will have testing, and this will become commonplace. Masks and hand sanitizers will be everywhere. Every restaurant, every place you go will have hand sanitizer, and masks will involve cloth masks and surgical masks. And I think, any mask is better than no mask at all, even if it's a scarf or a cloth, as the CDC has recommended. Parks have opened. I know in Broward County, there are a number of cities that have opened parks, and we're monitoring the activity in these parks, but parks are probably the first places you'll see open around the country, and we've already seen that here in our county. And retail businesses, you can look at the executive order from the governor yesterday and get a feel for what type of businesses will open, but restaurants will be at low capacity. They're starting at 25% capacity. Schools are going to be a big issue, and I think everybody's trying to work through that. But things like teachers cleaning every desk with sanitary wipes between classes, expanding the number of hours for lunch so that kids aren't sitting close to each other, avoiding all sports activities, things like that. There are going to be many things schools will do, and I cannot predict whether school will start in August, but my gut feeling is that it probably will, with a lot of rules. Office buildings, elevators, things like that will have certain guidelines, and probably one person per elevator, hand washing and avoiding touching buttons and things like that. Maybe even every building will have an elevator monitor to press the buttons. Movies, concerts, and sporting events, for those of you that like these things, you're not going to see these anytime soon. And I would probably predict you're not going to see these things happen the way we used to do these things until next year. And vaccines is a whole nother discussion, but they are rapidly moving through technology and testing for vaccines. And I think sometime before the end of the year, we will have a vaccine. because there are a lot of places developing vaccines at this time all over the world. And a few last slides here, and I thought this was an interesting slide because it really shows you, there's all these theories about where did this virus come from? Was it produced in a lab? And, is it a terrorist attack? And the reality is, if you look at the number of viruses and infections, and these viruses are known as zoonotic viruses because they originated in animals and somehow went from an animal to a human. But if you look at this over time, every 10 years, we're seeing more and more viruses in our world, in our social places that we frequent. And we're seeing more and more epidemics. And the reason is, as a population, we're growing, and these viruses have lived for millions of years in nature, infecting animals. But as humans continue to, populate the world and tear down rainforests and things like that, you're going to see more and more of these infections. So for those of you that think coronavirus is going to go away and we're not going to have any problems after a vaccine is produced and effective, I'm here to tell you that viruses are going to be here, and there's going to be different viruses and different infections, and we have to live differently as these things present themselves. And although this is a financial slide, it kind of does show you a little bit of information with respect to epidemics in the world. And this particular graph shows the impact it's had on the stock market. But what was very impressive to me is if you look at the HIV epidemic, which started in 1980, and really, for a good 10, 15 years, there were no epidemics after that until a pneumonic plague epidemic. And then we had SARS. And then if you look at all of these other things that have happened, they've happened very frequently. Every couple of years, there's some other, we had Zika a few years ago. There's been a measles outbreak, Ebola virus, and now we have the COVID-19 pandemic. So I think we have to be realistic that these things are not going to go away. We have to live differently. We have to be more thoughtful in the things we do. And at that, I'll leave this last slide, which has my email address as well as my Twitter feed. And I did want to plug the next week's webinar, which is next Thursday at 2 p.m., same time. This webinar will be hosted by Dr. Lenore Walker, who's both an NSU alumnus as myself and a professor at NSU's College of Psychology. She'll be talking about how to stay safe at home. And we know that abuse, both spousal abuse and child abuse, those are things that we've seen more of through this pandemic. And I think it's a really important topic for everybody to tune into. And with that, I'll take a few questions. I'm gonna read through some of these questions just to kind of see if there's any questions I can answer. So one of the questions is the hospital or my doctor's office safe? And the answer is yes, it is. I could tell you that in theory, the doctor's office or the hospital may be safer than the supermarket. We test everybody. We use all kinds of things to make sure that our population, both in the hospital and doctor's offices, are safe. So as far as whether it's safe to come to the hospital if you're sick, we've definitely seen issues with patients not wanting to come to the hospital with chest pain and other things. And I think if you look at some of the statistics out there, the number of cardiac arrests have gone up through this pandemic. All types of stroke issues we've had now. We've had the stroke volume go up in our healthcare system. So we've definitely seen the collateral damage this virus can cause. And I would encourage anybody who's seeking medical care to not be discouraged by going to the hospital or the doctor's office. These places are safe. And we have less and less patients that have COVID-19 in our hospital. And these are very safe places to go at this point if you're sick. And obviously, if you're not sick, you don't belong here. I'm going to read through a couple of other questions here. So it says, I'm flying this evening. What are a few precautions or tips you have for me? Flying is going to happen again, and people are going to have to fly places. And I would tell you that flying is a risk. And the most important thing is to wear a mask, specifically if you have a quality surgical mask or N95 mask, for instance. A good quality mask is really important. High touch surfaces like, don't put your, table down and put your hands on it. Bring hand sanitizer, don't use the bathrooms. I would sit still on your flight, wear a mask, avoid touching things and get off. And in general, as long as you do those things, as long as the numbers stay where they're at, flying will be a reasonable option and something that, is, although risky, not extremely high risk as long as you do those things. This is an interesting question. Somebody's asking about blood clots and DVTs, and there's been some interesting information, and we are running a study here through our IRB on clotting and looking at the incidence of clotting. And there is a lot of speculation that this virus does increase clotting, particularly early on in the infection. And then once a patient gets really sick and gets critically ill, they actually become hypocoagulable, meaning less and less clotting and actually propensity to bleed. So a lot of patients we are putting on blood thinners early and then actually taking them off the blood thinners as they get sicker, because those patients tend to have a higher incidence of bleeding. But nobody really knows for sure, which is why we're studying this. But we do think that there is some impact on clotting and microvascular clotting in the lungs and some of the other tissues. And it says here, have you heard anything about non-essential dental visits and if there are any new precautions? Well, I can tell you the governor's executive order did allow dentist office and medical offices to open. I believe the executive order goes into effect next week. So you will see dentist office open not only for emergencies, but for non-essential dental visits. And I do think that there will be the same precautions in place as any other healthcare provider. You may be screened for your temperature. You will probably be asked to wear a mask. All the providers will have a mask. And I imagine there will be lots of sanitary sort of cleaning going on in these places in between patients and, at the end of the day. And we have time, I think, for one more question. It says, if I get tested and the results come back negative, why do I still need to wear a mask in a store? Because when you are wearing a mask, you're not only protecting yourself, you're protecting others. So if somebody in that store happen to have an infection, is releasing virus into the air, and you're not wearing a mask, there's a much higher incidence of acquiring that infection. And vice versa, if you had the infection, which let's just say you had a test which was negative, keeping in mind there are false negatives and there are times when you may have the infection early on and have a negative test. Out of precaution, you should still wear a mask because it does protect other people should you have an asymptomatic infection or a false negative test. So masks are extremely important, and we will be using those probably ubiquitously throughout society for the next few months at least, until the numbers come down or this virus is eradicated either by a vaccine or on its own biological cycle. And with that, I'm going to end this webinar. I appreciate everybody's attention. And I will try and answer any other questions afterwards through email if you do have any. My email address again is rkatz@mhs.net. Thank you and have a great day.